Dr. Rashmi, can you look at the chat box and ask the questions at the end of the case?
The chat, one has to log in by the attendee mode because the panelists will not be able to see the chat.
Is it? Okay.
Yeah. I mean, the panelist chat is different and the attendee chat is different.
Okay.
I've asked Rashad to
do that? Okay.
Yeah.
Okay, sure.
Okay.
So
okay,
yeah,
fine.
we'll start off.
Yeah.
Sure. Yeah, we'll start off.
Yeah, so good evening, everyone. Welcome to another session. At the outset, we'd like to thank Spin Academics for their collaboration for our sessions. It's a great platform and we are very honored to have them collaborating with us. And these session recordings will be available on the Spin website and also on the Rainbow Children's YouTube channel from next week onwards. And we also decided and also very thankful for the core panelists, Dr. Balthazar, Dr. Mankad, Dr. Hamid, and Dr. Taranath. They'll be our core panelists for these sessions going forward. We'll still be having the invited panelists, but yeah, these are the core panelists. Tentative format for this session is we have around 13 cases. We'll allot around 6 to 8 minutes per case. I'll go ahead with the clinical and imaging slides with brief differentials with the help of the neurologists and also the fellows. Once I discuss the imaging findings, the case will be open to the expert panelists for additional comments and suggestions. Attendee queries can be, I think, answered by Dr. Lokesh or one of the Rainbow Fellows. Start with the first case. If Dr. Juhi is there.
Yes, I'm there. Am I audible?
Yeah, you're audible. So what I've done is I've put the clinical symptoms in a sequential order as per the MRI. So maybe you can start off with how the child initially presented.
All right. Good evening, everyone. So this case, she's a 7-year-old girl and she presented last year. She was symptomatic since last year, January. So in January 2021, she presented with bilateral vision loss, left more than right, dysarthria, 7th nerve palsy, and a history of fever, which was not recorded. This was in another hospital wherein she received oral steroids, and these symptoms responded to the steroids, but not completely. Subsequently, in the next month, in February 2021, she again had a focal deficit in the form of left hemiparesis, and she was given 3 doses of IV methylprednisolone, leading to full recovery.
Dr. G, I can just interrupt you. We'll probably show the January scans and then probably you can let us know what was the progression of the clinical picture.
All right.
So this is how the child presented initially. In January with 7th nerve palsy, bilateral vision loss and dysarthria, and received oral steroids. So these are the external films, and we have T2 sagittals. On the T2 sagittal, you can appreciate that there are multifocal lesions in the supratentorial brain parenchyma, predominantly involving the white matter. Also involves the corpus callosum. The T1s, you can appreciate the lesions, but not as clearly as on the T2s. But again, predominant white matter involvement is seen along the peripheral white matter. So now coming to Feb. Yeah, Dr. Juhi.
So she responded partly to oral steroids, only to become symptomatic again in the next month, and this time with left hemiparesis.
And now we have
Could
the
I ask a
axial
question?
images. Yes, sir. Please go on.
Just wanted to ask you, was the fever prolonged?
No, sir. Fever was not prolonged, and fever was rather not a conspicuous complaint. It was undocumented. Okay. And these 2 episodes were treated in an outside hospital.
Sure.
Okay, so again on the February scan, we have these multifocal lesions, predominantly involving the white matter in the subcortical and the peripheral aspects. The deep gray nuclear basal ganglia and thalami demonstrate normal appearance. There's overall reduction in the brain volume. FLAIR images also again demonstrate these patchy multifocal hyperintensities. Cannot appreciate a restricted diffusion on the diffusion, maybe slightly in the frontal region and the subcortical area over here. Again, reduced volume, and you can appreciate the lesions on the sagittal images. Corpus callosum is relatively spared. I think these are the post-contrast images, and I cannot appreciate any significant enhancement on the post-contrast study. So again, that up to you. So at this point, I'm thinking you're suspecting para-infectious post-infection demyelination as a cause.
Yes. So in March or end of March or beginning of April, she presented to our hospital for the first time. And this time she predominantly had cerebellar signs along with a weakness of all four limbs. And this was the time when we suspected demyelination and sent serum NMO, MOG, and CSF oligoclonal bands. All were done by appropriate assays, including cell-based assay. They were done at Nihaal, and they were all negative. We still went ahead with the IV steroid pulse, and she responded completely, and there was no residual focal deficit.
Okay. So I have only the orbital images of the April scan, and you can appreciate that there is bilateral optic neuritis involving the mid and distal segments, right more than the left, but it is on both sides. So on to July.
So then again in the month of July, so this was the fourth episode in 2021 that she presented again with some gait difficulty and 2 episodes of seizures. And when we repeated the scan, because the findings had increased, we again decided to go ahead with another steroid therapy. And she responded again. So far till January 2022, she does not have any seizure or any focal deficit. And we repeated the workup. So we again sent NMO and MOG, which were negative. This time we did not repeat a CSF study. Also planned GFAP, but it was expensive. She could not afford that.
Okay. So coming on to the July scans, and you can appreciate the significant progression, predominant, especially in the parieto-occipital region. The lesions are now more confluent. There's also involvement of the posterior aspect of the sphenium of the corpus callosum. Basal ganglia is relatively spared. The peritrigonal region is involved. You can also appreciate some differential hyperintensities, probably suggestive of some areas of necrosis, some faint areas of restricted diffusion, but not very significant. And you can appreciate, so it's a predominantly confluent lesions in the posterior cerebral white matter and also in the peritrigonal regions. November again, the similar changes are seen in the posterior and mid cerebral hemispheres on both sides. Cerebellum and brainstem, I cannot appreciate any findings. Basal ganglia again are relatively spared. Post-contrast study. This is the post-contrast study, and I cannot see any enhancement of the confluent abnormality on post-contrast study. So after November, the next scan was in Dr. Julia. This was in January again.
I think the last one is of November,
Okay.
where the change.
Okay. So again, these are same changes, I guess. More going down, but again, you can see this confluent abnormalities in the posterior periventricular regions. Again, no enhancement on post-contrast study. Cerebellum is relatively spared. So I think probably go ahead with your comment, Dr. Jui. What the dilemma on the clinical and radiological aspect?
So every time the child responds completely to steroid, something behaving something like a MOG or maybe a leukodystrophy pattern of MOG, but twice it was negative, maybe we keep on repeating it. So we want opinion regarding a neuroinflammatory disorder versus a neurodegenerative disorder.
Just to point out what you have mentioned, the leukodystrophy type pattern in the MOG antibody related disorders, as you can see, it is pretty similar to what we have seen in our case, And this was a diagnostic algorithm for the relapsing demyelinating syndromes from Gauche. I don't know if Dr. Mankad is here, but since you have checked for MOG and aquaporin antibodies and the oligoclonal bands also negative, probably look for alternate diagnosis, but I'm not sure, at least on my side, what can be the possibilities. So I'll open the case for the panelists to discuss.
This is not my special field of expertise. I think, as you said, Dr. Gupta, this is a leukodystrophy-like appearance of a relapsing, likely demyelinating condition, and not all these conditions are antibody positive. This would not distract me from this working hypothesis. But since your first-line treatment is not successful on the long run, one should consider second-line treatment like rituximab or whatever. This I would consider. And I think genetic leukodystrophy is unlikely with this very variable pattern.
Okay, sir. Thank you.
Rajesh, any other input?
I think I'd agree with that.
I'm sorry. Go
Dr.
Can
Rajesh,
think
with
about,
any-
MMF,
No, go on.
oral MMF to prevent further episodes. Because rituximab is IV and all, oral, you can consider giving a bit more oral MMF but the thing is because it's antibody negative, you don't know which antibody it is, but at least you know that they have responded to steroids so many times. So
How old is the patient? I'm sorry, I missed that.
7 years.
7 years.
Yeah, the onset of the illness 7 years.
Yeah, I mean, it looks like a relapsing remitting inflammatory disorder. Only problem is that, leukodystrophy patterns of MOG usually occur in young children and take a significantly long time to improve. In fact, she responds immediately, right? Steroids?
Yes. Yes, sir.
Yeah.
Is there any cognitive changes or nothing?
Sir, formal DQ testing is not done, but as per father, she is learning new things. So no cognitive decline as per the father.
Can I come back? Did she have clinical evidence of optic neuritis? Because Nihaal, you said in the MR you see evidence of optic neuritis, but this is usually a clinical diagnosis, and it goes along with visual impairment. Without visual impairment, there is no optic neuritis.
Yes, sir. She had complaint of vision loss, bilateral, left more than right.
This is
And a
also,
fundus?
excuse me, last. This is also, I think, in favor of or is against a genetic leukodystrophy.
Right, sir.
Yeah. Anyone else wants to comment on the case?
Yeah, not
Dr.
all
Lokesh?
mark spectrum cases
Okay,
may
Dr.
have
Yeah.
antibody positivity. I think
Yeah.
even with rest of the assays, probably the highest yield will be somewhere around 60 to 70%. So I think although sometimes genetic conditions may not be completely excluded, I think best to put this child as second line immunomodulation.
Okay. Okay, sir.
Okay. Okay. So
Can
I
I
think I'll
ask you a
conclude the case. Yeah, please. Sorry.
Yeah, could it be collagen vascular disorder like SLE presenting early with mainly CNS manifestations? Because the response to steroids is quite good in all the episodes.
To 1
Can
year
you-
on, and there are no systemic manifestations, that would be very unusual, and predominantly one way involving the white matter throughout the course of the illness, and the nature of such confluent involvement probably would be unusual for a SLE vasculitic condition.
Okay, thank you.
The other shows no other system involvement, no hepatosplenomegaly, no phagocytosis, nothing like that.
For HLH, no?
Yeah, because isolated CNS HLH doesn't have a clear-cut picture, which you can get cerebellum, you can get white matter, you can get pons. I'm just saying, since this is so atypical, would we want to rule that out?
Yes, ma'am. No features of systemic HLH as yet, and plus no features of hemorrhagic nature of lesions which is seen in isolated CNS HLH. So as of now, she hasn't developed any such features.
Okay, we'll move on to next case.
Okay. Next case, I'll hand it over to Hiren and Dr. Anatha and Dr. Shreya.
Shreya, are you
Hello,
there?
good evening, everyone. Can you hear us? Yes,
Yeah,
ma'am.
please go.
Can everyone hear us? Okay, so today we are presenting the case of a 13-year-old girl who was second born of a non-consanguineous marriage. She had a normal birth and development history, and she was completely okay till 1 week before the onset of illness. Before admission, she started developing pain in abdomen, vomiting, and fever. Was initially managed on oral medication at home for 2 days, after which she developed loss of appetite and needed to be hospitalized as she stopped eating anything. After hospitalization, she started having increased work of breathing in the form of acidotic breathing. She had a deranged ABG. Her sugars were very high. Urine had glucose and ketones positive. And HbA1c was of 12.3. She had acute kidney injury in the form of raised creat, and her sodium was 129. There she was diagnosed as a case of diabetic ketoacidosis, and accordingly her treatment was started. The next day her sugar started decreasing, her sodium started improving, but her GCS was decreasing and she was not improving, and hence she was referred to us. On admission, she had a GCS of 5/15 and hence required to be intubated, and then she was further investigated. Can we click on the next one, please?
Yeah.
On admission, her hemogram was normal. She still had a deranged ABG. Her sodium had gone up to 162 from a previous two-day previous sodium of 129. So next, please. At this time, we thought that this was a decay which was decompensated due to some infective etiology with a suspected pontine myelinosis, and an MRI brain was done. Can we go on to the next slide?
Yeah. Hello, everyone. So these are the representative MRI positive findings. So what we can see here, these are the top row shows T2 Excel sequences in which we can see that there are bilateral, however asymmetrical T2 hyperintense lesions were there involving the bilateral basal ganglia. If you see that dorsal thalamus on the left side also it was involved, and here we can see at the basal aspect, anteromedial aspect of the temporal lobe, as well as basifrontal areas along the middle aspect were involved. So as the brainstem. The brainstem, we can see that this kind of multiple patchy areas of hyperintensity involving the both sides. It was more on the right side than the left side. And subsequent images shows at the level of pons, we can see that on the left side, adjacent to the middle cerebral peduncle, we can see one discrete hyperintense lesion. So all the above mentioned lesions, they were showing restricted diffusion with a low ADC value in the central part and some peripheral high signal intensity on ADC. And the last two are the post-contrast images, which does not show any ring enhancement or any particular pattern of enhancement on above mentioned lesions. Can you go on to next slide? Yeah, next slide. We also had done at the time T2 spine screening, which did not reveal any spinal cord abnormality. These are the representative images, which is showing the optic chiasma. So there was thickening and hyperintensity of the optic chiasma. If you can see that the bottom row shows the T1 fat side pituitary imaging, which shows that there was loss of T1 posterior pituitary bright spot, and on contrast enhancement there was like suggestion of infundibular stalk enhancement. And on the second image from the top shows that there was involvement of the hypothalamus. As we can see that hyperintensity was seen along the middle aspect of the third ventricle. So based on this finding, multifocal asymmetrical areas of involvement with restricted diffusion with this pituitary and optic chiasma involvement, we thought that this could be inflammatory pathology or a vasculitis related infarcts. The second possibility we kept as an infection, viral infection causing this kind of damage to the brain. Or third possibility, considering the location of the lesions and involvement of the optic chiasma near the third ventricular and hypothalamic area, we kept as a demarcation as less likely, but as a differential, like an NMO spectrum disorder.
So accordingly, she was further investigated. So can we have the next clip? She was started on treatment with insulin infusions, antibiotics, and supportive treatment in lieu of inotropes because of she had hypotension. At the same time, her liver function also started getting deranged. Her bilirubin started rising. Her SGOT and SGPT were elevated above 6,000. She had a high ammonia. A CSF examination was done, which showed 10 cell counts with high sugars and proteins. So next, at this next click. At this time, she was gradually weaned off inotropic support and sedation. However, there was no change in sensorium. An EEG was done which showed diffuse slowing and a metabolic encephalopathy. On examination, she still had a poor GCS, was still having fever spikes. She was getting increased tone with brisk reflexes. We further investigated along the lines of our differentials. A CSF gene export and viral panel came negative. A CSF plus serum NMO, MOG, and oligoclonal bands were also negative. Her COVID antibodies were, however, positive, and all her inflammatory markers is also elevated. Her liver function kept on deteriorating. The next slide. Suspecting an inflammatory reaction, a COVID MISC, or a demyelination, she was started on IV steroids and should be pulsed off with injection methylprednisolone. After this, on further investigation, for the cause of DKA, her insulin antibodies were negative. So on the next page, please. Her workup for any inflammatory or vasculitic pathology also came negative. However, her ACLA IgM was positive and ACE was borderline positive. On investigating for the liver involvement, we found that her anti-HAV hepatitis A IgM was positive. Rest all investigations were negative. She still had diffuse slowing on EEG. Her ophthalmic exam was within normal limits. On day 7 of admission, she had one episode of seizure, following which her sensorium deteriorated even further. At this point of time, we thought that whether she had developed some critical illness neuropathy or whether this is some demyelinating process which has progressed further and has now involved the spine also. We did an EMG NCV which showed a diffuse axonal type of sensory motor generalized polyneuropathy, and an MRI brain and spine was also repeated.
Yeah. Next slide, please. Yep. Can we move on to the next slide? Yeah, so these are the second set of images which we repeated after 1 week. Previous slide. Can we go to the does not reveal any major vessel occlusion. It was not showing any features of large vasculitis.
Hiran, I can't hear you. You're not audible.
The previous slide.
You want the next slide?
One. Slide before. Previous.
Yeah.
The one before, previous. Yeah. So these are the representative second set of images. Here we can see that there was no worsening of the previously mentioned or previously seen. However, on SWI sequences, we could see that this time we were able to appreciate punctate hemorrhages along the margins of the lesions, especially near the globus phallicus and especially near the ventral aspect of the brainstem, as we can see on SWI sequences here. We could also appreciate some few more areas of microhemorrhages in the which are diffusely scattered at the gray white matter as well as deep white matter junction. Due to this microhemorrhages, we could appreciate on the non-contrast scan itself, there was peripheral T. So there was no actual enhancement of the lesions. Yeah.
Next slide, sir.
Nihaal, can we go to the next slide? This already we have discussed.
Okay.
Yeah. After 1 week also, we went for one more scan just to look at the etiology, since the child was not waking up and we did not have any clue, but that did not show any much changes in the scan. So based on all this lab findings and clinical picture, we concluded that there are 2 or 3 possibilities in this case. Either it's a case of vasculitis, which can be associated with the systemic disease like ACLA positive status. And in vasculitis, usually we see this kind of watershed territory infarcts, or they can have vasoganglia infarcts, they can have arterial stenotic lesions and tendency for arterial or venous thrombosis. That is one of the possibility. The second possibility we thought as a, after going to the literature, next slide. Yeah, so we went through the literature that what are the neuroimaging finding in the pediatric diabetic ketoacidosis. In that, we found that diabetic ketoacidosis itself can have infarct or hemorrhagic lesions, which can be independent of cerebral edema. That is because of hyperviscosity or blood-brain barrier disruption or endothelial injury, which can lead to this kind of multifocal infarcts. So this case actually represents images like us. So that we thought that this could be another possibility. And next slide. And our last possibility, we kept that this could be some sort of viral infection which would have progressed into a necrotizing stage. So that could be a sequel of acute necrotizing encephalitis. So these are the things that we were thinking at the time. Any comments from the experts, please? Any suggestions?
That was a good presentation, Hiren. I was looking at it, and in the I'm still not able to reconcile how we will explain the involvement of the pituitary stalk. Is there an explanation amongst any of these differentials that would explain how the pituitary stalk was affected? I must say that when I saw the pituitary stalk thickening and enhancement, I was like everybody who would look at it in isolation of the imaging would think of LCH. And
that we also thought
parenchymal lesions were possible, but not very common manifestations. I mean to say that the manifestations in your case are not typical of the neuroparenchymal lesions we see in LCH. But that was one possibility that I was thinking. And then I saw the subsequent imaging and then the several lab tests. I agree with the differentials that you have put up, but in my mind, I'm not able to understand why the thickening of the pituitary stalk occurred. Have you considered doing a skeletal survey on this patient?
We have not done yet, sir.
We've thought of LCH, and we've sort of ruled it out investigation-wise. She has no other features suggestive of it. We were actually running down the inflammatory pathway all along until we saw that article that DKA actually can present exactly with the same type of features, and usually a DKA when it's precipitated by an infection or a virus or something like that. The COVID was the first thing we were thinking of as well, COVID antibodies when multiple system, but I think the liver was, I think the HAV precipitated the DKA in a child with a predisposing diabetic, with a diabetic predisposition. And those MRI findings we found very difficult to take. But then when you see the literature, I think it fits quite well with this. I agree, the pituitary stalk was a little odd. Can I ask, at a young adolescent 14-year-old girl, the swelling of the pituitary and all that, could we put that all as, could you account it with adolescence? And
no, you wouldn't get a thickening of the stalk and an enhancement. I presume you are saying hormonal changes associated with her menstrual cycle and this and that. I haven't seen anything that causes that degree of thickening and enhancement. That appears to be pathological. Moreover, the fact that it is thickened associated with the lack of posterior pituitary bright spot means that there is a pathology which prevents the messages from the hypothalamus to enter the posterior pituitary. So there is a pathology there for sure.
Can I make a comment?
Yeah, please.
Yeah, I've seen this case. I think Anita showed it. And, I actually thought of a COVID-related inflammatory disorder with the COVID antibodies, the fact that, punctate hemorrhages and white matter disease has been described in COVID. And this interesting thing about the pituitary stalk, so I just checked it. In fact, COVID-19 does cause pituitary stalk enhancement and thickening. So I think that will explain everything.
COVID can cause anything these days.
I know, but unusual.
I'm not dismissing what you said, Dr. Udani, but just I'm saying, this COVID can do anything that we are not aware of. It can do so many things, I guess.
It can cause hyperphysitis. It can cause diabetes insipidus. It can cause hypertension. It's amazing stuff. I think if you look at the whole picture of inflammation, evidence of COVID, evidence of hemorrhagic punctate hemorrhages, white matter changes, plus pituitary stalk, And decay. Nowadays, we know that decay is precipitated very often by, and lots of reports of decay being precipitated by COVID. Now, how that, whether she's already had some mild, because I don't know, but whatever it is, there seems to be all COVID-related complications.
So the decay with COVID is there because we have a second one now with the decay secondary to a COVID. So I think it does predispose to it. Plus the microhemorrhages were a feature which made us think more towards the COVID. But it was, I mean, we've treated it that way, but we weren't sure what we were looking at.
Did this patient have polyuria?
No.
Because of insipidus, diabetes insipidus also?
No. She's touch wood recovered, but she's been left with significant sequelae. Thank you.
Okay. All right. Thank you. Thank you very much.
Nihaal.
Thank you. I'll quickly move on to our next case. Is from Dr. Rashmi. So the 6-month-old baby presented with viral gastroenteritis in the form of diarrhea for 2 weeks and fever for the first 2 days of illness, followed by encephalopathy for the last week. EEG was abnormal in the awake state. However, in the sleep state, it was normal, demonstrating spindles and vertex. There was a single episode of myoclonic jerk with left temporooccipital generalized spikes. The blood workup and the inflammatory workup, along with ammonia, calcium, magnesium, was normal. Lactate was 3.5. CSF lactate was slightly elevated at 29. The child was started on mitococktail, and the sensorium improved and was discharged. Anything you want to add, Dr. Rashmi? We go on to the MR images.
No, that's about it. It's a child who came with a little bit of encephalopathy, just not responding at all. And for a 6-month-old baby, it was quite an atypical, but no other deficits or anything.
Did you evaluate for biotin and thiamine by any chance?
Yeah, we started her on biotin. We started on mitococktail, so we started on everything. Okay. Biotin.
But you didn't check. We didn't check for any deficiency. Right?
No, we did TMS and biotidinase, which was fine.
Okay. Slightly distorted images, but here you can have on the top panel, we have the diffusion varied sequences. So bilateral symmetrical areas of vesicular diffusion in the dorsal striatum and also in the centromedian nuclei of the thalamus on both sides. Some areas of vesicular diffusion also involving the anterior cingulate cortex on both sides. And corresponding images on T2 demonstrates these hyperintense changes in the dorsal striatum, the median thalamic nuclei, also the periaqueductal gray matter in the brainstem. There's some degree of volume loss in the supratemporal brain parenchyma. And on spectroscopy, there is an inverted lactate peak. So considering the imaging findings alone, one would think of a biotin thiamine responsive base ganglia disease as one of the possibilities. And also Leigh syndrome can also present with similar phenotypes involving the dorsal striatum and also the periaqueductal gray matter. So those two are the differentials which needs to be considered, at least according to this case, and I'll open the case for discussion.
We started her on mitococktail. She came back for follow-up, and her parents reported that she's much better than what she was before. I still haven't gone ahead with the genetics yet. But during her presentation, when we admitted her with the encephalopathy, I was thinking about post-infectious, but obviously she didn't have any fever. And so we didn't go ahead on that route at all. So we did CSF analysis, which was cell count, protein, and all were normal. So we didn't go beyond that. So that's about it.
So the only thing is that favoring the biotin thiamine is the involvement of the cortex, which is slightly unusual in my primary mitochondrial disorders. So if anyone else wants to comment on that.
Are you considering genetic testing, or have you already started to do this?
No, genetic testing, I've had a discussion with the parents about it. Obviously, it's an expensive test, so they want to think about it. So I just left it with them for the moment.
I think the overall imaging and MRS and your CSF is very much in favor, as you have assumed, a mitochondrial disorder.
The lactate was high, and CSF lactate also slightly on the higher side. So we treated her with all the supplements.
I had a question for the radiologist. Do you think this is more of a pyruvate disorder, or do you think it's more of a respiratory chain? Because this looks
Respiratory
like
chain. Pyruvate
you
usually,
think,
I think, at least according to me, involves the globus pallidi more than the dorsal striatum. So these are imaging phenotypes of pyruvate disorders involving the dorsal striatum, the globus pallidi. The dorsal striatal lesions and the periaqueductal, we think of respiratory chain. And also biotin thiamine, that is another differential which you need to consider.
but biotin thiamine gives this periaqueductal changes, is it?
Yeah, it's pretty typical. So here's a case of the biotin thiamine related disorders. The periaqueductal, the thalamus is involved, and also there's involvement of the cortex. It can be symmetrical and asymmetrical, which is slightly unusual for a primary respiratory chain disorder. So yeah,
Sure.
the periaqueductal remata is commonly involved in biotin thiamine related disorders.
Dr. Nihaal, last week, 2 weeks back, when you presented us Dr. Lokesh's case with similar radiological findings, and they had anti-dopamine receptor something you were saying. No?
Yeah. Suspecting. Yeah. So here's an
So
example of anti-dopamine too.
Radiologically,
The periaqueductal is not involved. It is slightly patchy as compared to a mitochondrial disorder, which is more confluent. If you see the entire dorsal striatum is involved, whereas the antibody-related disorders can be slightly patchy and asymmetrical. And obviously, the clinical presentation is slightly different. I guess.
Okay.
The similar
that's
involvement,
very-
but without the cortex, I have seen
Yeah.
with hemolytic uremic syndrome. But obviously, the periaqueductal gray is what tilts it in favor of what Nihaal was saying. Initially, when I was had not had a look at the imaging and was reading the clinical, I thought maybe we are dealing with a situation of hemolytic uremic syndrome, given the diarrhea and gastroenteritis.
Yeah. That's
Just
very
two quick
helpful
comments.
discussion. Thanks, Dr. Nihaal.
Just two quick comments, just for clinicians' practice. I think thiamine deficiency, nutritional thiamine deficiency is still quite common in some parts of the country. It may be worthwhile if you have similar cases just to check thiamine levels. And obviously transcutaneous levels would be much more accurate. But if you don't have, at least thiamine levels will be helpful. Second thing is, one of our fellows is doing his dissertation on acute basal ganglia lesions. The yield seems to be very less. For metabolic and genetic testings, it is probably something like 25 to 30% cases, we might get some genetic confirmation. Otherwise, most of the cases will have unknown cause, especially in the infantile age group.
Okay. Yeah. Thanks, Dr. Ramesh. Yeah, sorry.
The transketolase levels you said, no? Is it worthwhile checking? A lot of infants come with thiamine deficiency, right? They come with a cardiomyopathy and all that on our ICUs.
Yeah, cardiac phenotype is one, but some of them may not have cardiac presentation, but present with primarily encephalopathy and these imaging findings, which look almost similar to thiamine transporter deficiency.
Oh, I see. Okay, fine. Okay. Thank you. That's very helpful.
Okay, right. Quickly move on to a case 4. Sorry for that. Is Zamya there, doctor?
Yeah, I'm there.
Yeah.
So, this child is a 7-month-old boy who presented first child of consanguineously married couple. So, this child had a normal perinatal and then presented with developmental delay. And on examination, developmental delay in all terms. The child was not having neck holding, no rollover, and then occasional eye contact to the mother. Recognizes mother, and the motor delay is predominant. And on examination, child had macrocephaly as well as prominent dystonia. So there were no point regressions or acute insults in the 7 months. This is the first time they have come to the hospital.
Okay. Going on to the images, if one of the fellows want to take it over, Dashrath. or should be, or in one. Okay, so I'll go ahead with the findings. On top, we have the diffusion weighted sequences, and you can appreciate that there is extensive areas of restricted diffusion along the periventricular regions, also in the subcortical regions. They're also asymmetrically involving the global pallidi and the hypothalamus on both sides, and also involving the temporal lobes and the central tegmental tracts. On the T2 weighted sequences, you can appreciate that there is bilateral subdural collections, signal changes in the deep gray nuclear predominantly in the global pallidi, and also some white matter abnormalities in the cerebellum hemispheres on both sides. The corpus callosum is slightly thinned out. And again, on the FLAIR and the SWI sequences, you can appreciate these bilateral subdural collections. So these constellation of features that on imaging alone is rather specific or suggestive of glutaric aciduria type 1. And I think, Ramya, we have a follow-up for the...
So clinically also, Clinically also, I was thinking of GA1 only in this child, and MRI is also having those features. And we have sent TMS and urine organic acid, which is corresponding to that. We have started the child on diet, and worth noting is that this child didn't have any acute insult. Like generally they present with that. There is one more presentation like this as well in this GA1.
I forgot to mention the typical under-localization of the Sylvian fissures also. So these are the findings, the typical findings which are seen in our case. The Sylvian fissures are under-localization, bilateral subdural collections, deep gray nuclear involvement, especially the basal ganglia, white matter changes, the brainstem abnormalities and cerebellar white matter abnormalities can be seen. The Sylvian fissures can have arachnoid cysts in the form of some asymmetry. They can be also be asymmetrical, not always symmetrical. This is a paper which I didn't have access to, but they have described enlargement of the optic chiasm as one of the features of glutaric aciduria. It's around 60% of the cases which they evaluated had this finding. So this is another additional finding. But I think these features are pretty pathognomic for GA1. If there are no comments, I'll move on to the next case. Again, it's from Dr. Ramya. Ramya, do you want to go ahead? Ramya, are you there? Okay, I'll go ahead. It's a 2-year, 7-month girl with developmental delay, mainly in the form of speech delay and excessive drooling. Also had microcephaly. I think the clinical phenotype was mentioned as a Worcester-Drought syndrome. For radiologists who are not familiar with this syndrome, they present with congenital suprabulbar paralysis, some abnormalities of expressive speech delay such as dysarthria, can also have seizures and mental retardation. The orbicularis oris muscles demonstrate some degree of weakness. They can be weakness of the tongue and soft palate muscles, which result in drooling. They are usually microcephalic and they have abnormal EEGs, and the inheritance is autosomal dominant. Moving on to the images, these are the T2 images. On top is the axial images, and you can appreciate that the cortex is abnormal. The bilateral frontal lobes demonstrate this polymicrogaric pattern. You can observe over here as compared to the posterior parietal region. This is the normal cortex, and this is the abnormal polymicrogaric cortex. The pedicilvian region also demonstrates some abnormality. There is again widening of the Sylvian fissures, left more than right. Coronal images, the parietal over here demonstrates some areas of polymicrogaria, pedicilvian polymicrogaria, predominant pedicilvian polymicrogaria, and also the frontal regions are involved. The brainstem is abnormal. There is hypoplasia. It's dysplastic and hypoplastic horns, and also some degree of dysplasia of the corpus callosum. So at this point, I'd like to,
my connection got cut. So clinically, this child, I was suspecting Worcester-Drought syndrome because of significant drooling as well as dysarthria, though her receptive language was better. Her expressive language was not good, and motor delay was not very significant, and child also had microcephaly. So Worcester-Drought versus perisylvian polymicrogaria, opercular syndrome, these two things we were considering clinically.
Okay. So here is just before I open the case for the panel, here's a review of literature of the Westerdahl syndrome. It's a paper published in 2000 where they evaluated cases with Westerdahl, and the primary, at least the MR abnormalities, demonstrated bilateral pedicellin polymicrogyria, especially in the paper in 1993, where 31 of the cases had bilateral polymicrogyria. The common clinical presentations were epilepsy, abnormal EEG receptive language abnormalities, and expressive language abnormalities. Another review of literature again demonstrated the suggestive features of Westerdahl syndrome. Again, gross motor delay, pyramidal features, expressive language delay, drooling, to seen in our case, and also bilateral pedicellin polymicrogyria is commonly seen in the Westerdahl syndrome. So I think the clinical and the imaging phenotype probably fits Westerdahl syndrome. Though I don't know
it's matching.
Have we sent
No,
it for
no, not yet. They'll come back. I'll send it.
Okay, so I'll open the case for any comments. Yeah, Edwin.
Can I question or comment? I know that paper, your comment was very fast, Nihaal, but if you go back again, I think this condition is not an entity at all, and genetics is not proven. And at least, I think, a third of the patients have normal imaging. So this is kind of a clinical constellation. There are also patients who have a similar clinical after herpes encephalitis. So Paris-Hilvian syndrome, as it is also called and discussed in that paper, is perhaps a better term. It's definitely not a proven dominant inheritance. I may be wrong, but this I heard the first time.
I agree with you, Eugene. The first time it was described as a congenital bilateral Paris-Hilvian syndrome and not as a Westerdahl syndrome.
In terms of how do you say, education, I have seen not many patients, but because they have so severe bulbar involvement, they have no expressive speech, and they may be underestimated in their cognitive abilities. And sometimes, how do you say, assisted speech tools can help these patients to communicate.
Okay.
Just a comment, we've seen similar things with HIE also. Perisylvian gliosis. Similar clinical picture.
Right, thank you. So I'll move on to the next case.
Thank you all.
Prabjot, are you here? Okay, I'll go ahead with the case. I think this is a 10-month-old child presented with congenital right hemiparesis. There was developmental delay. The child was not sitting independently at the age of 10 months. There's no regression. Birth history is a 2.6 kg child with meconium aspiration. No history of birth asphyxia, but there was some respiratory distress which didn't require any mechanical ventilation and was not consistent with neonatal encephalopathy or HIE. There was no seizures. The lactate was slightly elevated, CSF lactate. And as per Prabjot, I think she mentioned that it is more of a static kind of presentation, but maybe too early for a 10-month-old child. I'll go ahead with the images and then we'll open the case for discussion. So here we have the T2 axials on top. You can appreciate this bilateral periventricular and deep and superficial white matter abnormalities. There is a squaring and a dysmorphic appearance of the lateral ventricles on both sides. Some hypointensities along the right peritrigonal region, and also some degree of volume loss. The corpus callosum is severely narrowed. The anterior and the posterior aspects are equally narrowed. Cerebellum does not demonstrate significant abnormality. There is some degree of pontine hypoplasia. Cannot appreciate any cystic lesions in the white matter, maybe a slightly tiny area of cyst over here in the right frontal region. And on the GRE images, we can appreciate these areas of blooming in the right frontal region, also in the bilateral peritrigonal regions. So I think the question was, is this a PBL or is it a mimic? And the case is open for panels. Yep.
There is a paper by Nihaal et al. In Journal of Child Neurology where this situation is discussed, isn't it? So
yes, sir.
So this is likely prenatal bilateral event, and you have evidence of earlier hemorrhage with this hemosiderin still lying around. So this is likely an acquired condition, not genetic.
Okay. Any other comments?
May I ask something?
Yeah.
This is Dr. Juhi. So I think there is a paper by Dr. Adam Kitten's group on neuroradiological patterns of PPIS, presumed perinatal ischemic stroke. So will this sort of fit in into the PVI, that periventricular venous infarction, that PVI pattern of antenatal vascular insult?
But it is present on both sides. No, I think that is usually present on one side, if I'm not mistaken.
It can be present on both sides. There will be areas of hemorrhages, which is there in this case.
And as the child already had congenital hemiparesis, so it is likely to have an antenatal ischemic insult. So yeah, possible, I guess. Just a question to Aigen, would you expect the brainstem changes for PVI? Do you agree that the pons is slightly reduced in height?
Valerian.
Can you repeat the question, please?
The brainstem, do you expect that in PVL too?
The pons is a little bit short, but in the overall context and in the overall, I call it hierarchy, this is a minor anomaly. I would not pay too much attention on this.
Okay.
I think it is the result of reduced white matter volume in the supratentorium, Nihaal, that the fibers that are going using the brainstem have reduced, which is why the brainstem caliber is reduced.
Dr. Nihaal, can this be a collagenopathy? I think probably I mainly wanted to ask this question, whether it can be genetic.
They usually present with more asymmetrical type of pattern, more of a porencephaly, sylencephaly kind of thing.
But PVL is a described phenotype of call for a...
Yeah. Initially, I thought it can be possible because of the hemosiderin staining, but
Because if this is a first child, we have implication for antenatal diagnosis for the next pregnancy. That's why.
Dr. Tarnath, do you want to comment on that? I actually thought of a possibility.
I was thinking that in this situation, maybe we could do an eye examination and a kidney ultrasound, KUB ultrasound, to see if this is a call for A1 or 2. Is there any manifestation inside the eye, or is the kidney function abnormal? That could be a starting point, apart from costly genetic testing. There is white matter volume loss. Whether you know what term we give it is a secondary thing. There is white matter volume loss with some hemorrhagic changes and reduction in the caliber of this neuroparenchyma diffusely. You see bifrontally the diameter of the neuroparenchyma is reduced. So this is going to result in a reduction in the bifrontal calvarial growth over a period of time. I think it's worth testing for the genetic basis behind this clastic insult.
Okay.
No point. No argument against this. I don't know how expensive this genetic testing is in your country or in your area.
It costs something around 15,000 rupees to 20,000 rupees. So around 50, I think $200.
$200 to $300, yeah.
Yeah.
Hello, Nihal. Sorry, I could not unmute myself earlier.
Yeah.
So I heard the discussion. So I think Dr. Ramesh
Yeah.
did mention that whether to go ahead with genetic tests or not was the primary concern. Also because clinically the child has only one-sided weakness. And the MRI shows a kind of diffuse picture which does not fit in clinically with the one-sided hemiparesis. So that was another concern. So should I take it as an acquired insult or antenatal insult and let it be? Clinically, somehow it is not fitting. Like had it been a quadriparesis or a paraparesis, that would have still been okay. So that was another concern I had.
Prabjot, I'll answer that question because it's a basically you are thinking of something unilateral, but you are seeing bilateral findings. So I have a genetically proven collagenopathy case presented with hemiparesis. Okay, so when I was thinking of antenatal stroke or malformation of one hemisphere, something on those lines. But over time, you may see subtle pyramidal signs on other side also. Because it's too young now to demonstrate very prominent pyramidal signs, you might see it little later. So even with bilateral injury, maybe because of the brain plasticity on one side, we don't know what is the mechanism. They may manifest prominent unilateral findings.
Okay, sir. Okay. Thank you.
All right. Thank you. Moving on to our next case. If Dr. Abhishek is there. Dashrath, are you there? Okay, I'll go ahead. So it's an 11-month child born to third-degree consanguineous marriage. No history of birth asphyxia. Had seizures on day 2 of life, and has development related. At this stage, there's only partial neck holding, not recognizing mother, and has cortical visual impairment or cerebral visual impairment. The head circumference is 36 centimeters. There's generalized hypotonia. The deep tendon reflexes are brisk, and there is no weight bearing. So at this point, here are the MR images. The T2 axial images on top. Straight away, you can appreciate that there is some squaring of the frontal horns on both sides. And also, I think there is some abnormality or discoloration of the frontal lobes on both sides with some degree of volume loss. If you see the frontal lobes on the coronal images, again, they don't look as what we normally expect. There is no cortical thickening or dysplasia, but the overall gyration sulcation pattern is slightly abnormal. Coming down to the posterior, the thalamus, the base ganglia thalamus, they do not demonstrate any abnormality, no focal lesions. Coming down to the posterior fossa, again, if you appreciate on the sagittal images, I think there is some abnormality of the vermis. The normal lobular architecture is not seen, though the imaging might be on a thick slice. There is some degree of corpus callosum hypoplasia, and also the brainstem is abnormal. There is some degree of hypoplasia of the horns in comparison to the rest of the brainstem, and also the foliation pattern I think is slightly abnormal. It is going vertically as compared to a horizontal orientation. The clinical significance, I'll probably leave it to the experts. They did a cyst sequence, Fiesta sequence, and the olfactory bulge, and also demonstrate some degree of hypoplasia. And just have the axial images of the cerebellum and the brainstem. There was some degree of concern for probably microcysts, but on 3D viewing, I think these are just some areas of interfoveal spaces, just slightly abnormal, probably correlating with a dysplastic appearance. Yeah, so that is the imaging, and the question was, is it a genetic disorder, and which genetic disorder could it fit into? It showed in this case to Eigen previously, I think yesterday, and probably suggested that possibility of DOX7 related epileptic encephalopathy could be a possibility, but there is no facial dysmorphism, or at least was not noted. They can present with pontocerebral hypoplasia and cerebral vision impairment. So at this point, I'll open the case for discussion.
Nihaal, I'm not sure. Go back to the next advance. Next slide. Here in the middle up, you will not see my cursor. You see my cursor? My arrow? No.
No.
You are not convinced. You are not convinced that these are tiny cerebellar cysts in the area, and also on the mid-sagittal. It just comes to mind because we had such a case recently in Zurich, and DOC7 was confirmed. Heavily CVI, and also some facial dysmorphic signs. What about the appearance of this patient? Any abnormality?
I spoke to the referring, and he said you're asking for facial dysmorphism? I didn't get you, sorry. At least what he said is there's no facial dysmorphism, which is commonly seen in DOC7.
Well, for me, of course, I have limited experience, and the literature on DOC7 is also scant, but this for me would be the best bet, so to say, at this time.
Okay. Eugen, would you consider the not the diagnosis, but the finding of a macrocerebellum here?
Yes. Yeah. I mean, you would like, maybe you would like to have volumetric confirmation, but this cerebellum is really, really large. I would call it a macrocerebellum. It doesn't mean much because it's not an entity.
Would you then go along the pathway of the differential considerations for a macrocerebellum, or would we?
I think the yield is less.
The checklist with macrocerebellum is very, I don't have it in mind now, but it's not kind of a systemic checklist. Some Joubert, some syndromes,
Williams, Soto's Williams,
some neurocutaneous syndromes.
Any other comments on the case? Dr. Prasad says the olives are flattened. If that is. So dysmorphic brainstem with some degree of hypoplasia, macrocerebellum, microcerebellar cysts, and some frontal and olfactory bulb changes. Going towards genetic diagnosis, whole exome sequences suggested. So if there's no comments, I'll probably convey that to Dr. Abhishek. We are thinking of genetic disorder. Is that right, Dr. Eugen or Dr. Tarnath?
I'm thinking of, yeah.
Yeah, okay. Next case is from Dr. Ramesh. It's a child with neonatal onset epilepsy, had epileptic spasms, bilateral cataracts, developmental delay, microcephaly, spasticity of all the limbs, cerebral vision impairment, and Dr. Ramesh was suspecting a genetic etiology. Dr. Ramesh, you want to add anything to it? I didn't get the age of the child.
This baby is currently around 18 months or so. We saw this baby in the neonatal period itself because of refractory seizures presenting, I think, within a week of life. Even at that time, there was microcephaly. So that's why we thought this is something which has started in utero, and a very severe developmental delay. Was operated for cataracts because he has serial scans. So the initial genetic testing did not yield anything, but his cataracts developed after the initial genetic testing, and subsequent MRI findings are also new as compared to the first scan. So
okay. I think I have only one scan.
Oh.
I think this is the most recent scan which was given to me.
Yeah. We had another scan from your center only. If I recollect, there was some white matter hyperintensities, but there was no volume loss. Alami basal ganglia were normal, and otherwise parenchyma looked normal except for those non-specific white matter hyperintensity, which we commonly see in neonatal scans.
But now you can see that there is volume loss, significant white matter volume loss. Cavitatory changes have developed in the bilateral basal ganglia and the periinsular region. There is extraocular dilatation of the lateral ventricles. I cannot appreciate any cortical malformations. There is hypoplastic corpus callosum and the brainstem. These are the cataractus or post-op cataractus changes. Blooming, multiple areas of blooming, predominantly in the deep gray nuclei, which do not correspond to any calcification, so we'll take it as old hemocytin deposits. So that case actually reminded me of this case, which was previously discussed. It's a 3-month-old child with microcephaly, global delay. Again, a similar imaging appearance of these bilateral cavitatory changes and volume loss. And in this case, at least, there is some areas of calcification in the thalamus and the global pallidi. This case turned out to be a pathogenic variant of molybdenum cofactor deficiency. And I think the index child should be evaluated for COL4A12 as one of the possibilities, given the presence of cataract and also these asymmetrical changes in the cerebral parenchyma with hemocytin deposits. Dr. Prasad has raised a possibility of cocaine and Aicardi Guterres syndrome, which can also be considered as a possible differential. And now I'll open the case for discussion.
Yeah, his initial scan, as I said, in the neonatal period was very non-specific, and so because of the refractory epilepsy in the newborn period, we did genetic testing very early. Probably by 3rd month, we had the genetic test results. They were all negative for all the common single gene disorders. But now probably I think looking at the new changes which have evolved over time, we'll ask for reanalysis of the exome to include molybdenum cofactor sulfite oxidase as well as the Aicardi Gautier spectrum.
Could you do the uric acid and homocysteine?
Homocysteine, I remember normal. Uric acid, I don't think I have done.
If it's low, then it's helpful.
Yes, sir. Yeah.
I mean, we've seen a little later onset of molybdenum cofactor, but what surprises me is that the first scan was absolutely normal, is it? Or there was some change?
Some non-specific bright white matter was there, which we have seen in very like lot of cases in the neonatal period, very non-specific, and that's what I remember. But definitely there were no diagnostic clues on the first imaging.
The fundus examination, do you have any details of that?
It was normal. When he was evaluated for cataract, they did in detail. Nothing abnormal on retina.
Okay.
Are you looking for Aicardi Gautier clues?
No, I'm thinking of in the spectrum of Aicardi Gautier cerebroretinal microangiopathy with calcification and cysts. It's in the same spectrum.
Right.
I'm not sure if they've done a examination of the retina after the IOLs have gone in, because they wouldn't have had a good view of the retina with the cataracts.
I think they did follow up. But, okay, I need to check the reports. If there are any specific retinal findings they have mentioned post-operative.
This changes on SWI, they're not calcium, right? Usually Aicardi Guterres, you would expect calcium, don't you?
Yes.
There's no calcium. There's no calcium.
No. No infection, intervening infection, Dr. Ramesh?
No, it's a very quite significant delay from the beginning, and in fact there is some improvement. He did not have any.
Because of the non-specific first scan and the second scan, development of cavities and hemocytin.
No acute events in between.
Okay.
No crisis, no acute events.
So to conclude, genetic molybdenum.
Yeah. AGS?
AGS, yeah.
Okay, sure. We will ask to reanalyze the exam then. Thank you.
Next case, Romit, if you're here.
Yes, sir.
Yeah, go ahead.
So it's a 2.5-year-old child that presented with a very brief febrile illness of 1 day, which was followed by deranged sensorium irritability. And on the day of presentation, by day 4, he presented to us with, he was unable to sit without support. He had disturbed sleep-wake cycle, had decreased speech. And by next day, on examination, he had coarse tremors and cogwheel rigidity. Otherwise, he had normal perinatal history and developmental history. So we did CSF analysis, which was normal. Based on the scans, we also sent metabolic testing.
Yeah. Yeah, I'll show the scan first and maybe. So scan on top here, the T2 sequences, and you can appreciate this confluent areas of abnormality involving the basal ganglia, the external capsule, the subinsular region, also the central white matter. The rest of the brain parenchyma does not demonstrate any abnormality, no focal lesions or signal changes. The cerebellum did not demonstrate any abnormality. There is some degree of volume loss and some dysplasia of the corpus callosum. There is posterior drooping of the corpus callosum, so as to have some degree of underdevelopment. There is a bilateral inferior tonsillar ectopia. Also some degree of maybe thinning of the brainstem, in particular the midbrain. The pons belly is maintained. On the DWI images, you can appreciate cytotoxic edema in the bilateral putamen and also in the external capsules. Flare, again, similar changes are seen in the T2 weighted sequences. These are the T1 weighted sequences, which again did not demonstrate any hemorrhage, as you can see on the corresponding SWI sequences. The optic nerves, these are non-contrast flare optic nerves. I could not appreciate any edematous changes. Spine screening was done, and can appreciate some areas of myelitis in the cervical cord. I think the thoracic cord, these are movement-related changes. I'm not pretty sure if these are pathological or not, but at least the cervical cord is slightly swollen. Spectroscopy demonstrated a lactate peak in the basal ganglia. The rest of the peaks are normal. So at this point, thinking of disorders affecting primarily the basal ganglia, this is a paper which came out a couple of years back. And there's no history of acute poisoning, no uremia to suggest these. Oops. I'm sorry. Yeah. So no changes of uremia, no acute poisoning. Other possibilities are mitochondrial, but the external capsule involvement is slightly abnormal. So at this point, possibilities of autoimmune basal ganglia encephalitis shall also be entertained. Why we are saying this is because Romit, please go ahead.
Yeah, so based on these imaging, actually the MRI spine was not done initially because demyelination we didn't think of initially. So we did a metabolic test that was normal, and just thinking of a ADAM-like phenotype, I sent this NMO and MOG antibodies, and strangely the NMO antibodies were strongly positive in this case, although the clinical phenotype was more like an autoimmune encephalitis with loss of speech, a lot of extrapyramidal signs, sleep-wake cycle disturbances. So
yeah, so the question was, is this primarily related to NMO, or is there an epiphenomena of other antibodies being involved, or any other pathology? It's a two-way hypothesis. So yeah, the case is open for discussion.
Nihaal, can you go to the first MR?
Yeah.
Where you have seen the involvement of the external capsule, which of course is nothing pathognomonic, but the overall situation could also be explained by so-called ANE, acute necrotizing encephalopathy, which is not an entity, but this would be my first diagnosis on the list.
So you're saying that ANE and how do we explain the NMO? Is that a phenotype of ANE?
This ANE has been reported mainly following acute illness, influenza, whatever. You have brainstem involvement at times. I can't know the name. It's a dominant gene who can mimic, who can link this, but some patients have negative testing. And I have in mind that the involvement of the external capsule is, of course, not absolutely consistent, but is a typical finding.
Okay. The only question was how do we explain the NMO, strongly positive NMO antibody for this case?
Well, look, this is just one element. I mean, we have to take everything under consideration. NMO in a 2.5-year-old child is exclusively rare. So I would repeat this perhaps, but this is for me not NMO.
Okay.
So cervical myelitis is also a part of this ANE.
But the myelitis bit is not very, very convincing, Nihaal.
Yeah,
there is a very, very subtle T2 hyperintensity, but I do not see any expansion of the cord. Cervical minimal enlargement is within physiologic limits, I think, and therefore I would play that down. And as far as going into explanation of the basal ganglia involvement in NMO is probably because there is some sort of ischemia, pre-existing vasculopathy, and that has contributed to the aquaporin 4 mediated leaky blood-brain barrier and formation of these lesions in the basal ganglia. That is my hypothesis.
Don't you think the basal ganglia are a bit swollen? What happens in conditions like basal ganglia encephalitis and a group of anti-DR2 doesn't have to be positive, but it could be one of those disorders, or even basal ganglia. I mean, there's biotin, thiamine, though of course there are not many other lesions to explain that.
In fact, the T2 hyperintense rim around the putamen is a differential for ANE, ADEM, SLC, which is the biotin, thiamine, and the autoimmune basal ganglia involvement.
Yeah, and the without the thalamic changes. Yeah.
Sorry.
Yeah, same thing. Yeah.
Without thalamus and without hemorrhage is a little.
It's a bit atypical, yes.
Yeah. So how do we progress with the case? Do you suggest
steroids have been given? Genetics, yeah, steroids have been given.
Romit?
Yes, sir. We gave 5 days of pulse steroids. The child has improved somewhat. He has started sitting now, so it's improving. But cognitively, he's very poor as of now. He has not attained speech, and recognition is also poor.
He seems to have a Parkinsonian syndrome, so it might take some. Maybe you can give him some dopa as well. I don't know.
Okay, sir.
Okay. If there are no other comments, I'll move on to the next case. It's again from Romit. Yeah, go ahead, Romit.
Yeah, so it's a 8-month-old boy that presented with global developmental delay. He was born late preterm and did not cry immediately after birth, but did not have a very significant unilateral encephalopathy. In the form, there was no a significant resuscitation required. He was just under observation for 1 day, had no seizures, was feeding, and so on examination, he has significant microcephaly with central hypotonia, and I think we'll see the MRI next.
No cutaneous abnormalities, no?
No, sir. No, sir.
So here are the MR images. Again, changes involving the basal ganglia, but here the mid and posterior putamen demonstrate these cavitatory, symmetrical cavitatory changes on the T2 weighted sequences, which correspond to these CSF suppression on the flare. No districted diffusion on the DWI sequences. The cerebellum and rest of the brain parenchyma did not demonstrate any significant abnormality. This is a slightly, I mean, I wouldn't say it's an optimal quality, but this is the GRE sequences, and there are possibly two focal dots of blooming in the cavitatory lesion. Whether that is a calcification or a vessel passing through, I'm not sure. So these are the MR findings. Cavitatory changes, symmetrical cavitatory changes in the mid and dorsal putamen are the main findings, and this is the clinical picture. So the possibility is, do we go down the pathway of striatal necrosis? Is it acquired? Is it
So the doubt,
post-genetic?
yeah, acquired versus genetic, because was the that one day not crying at birth significant enough to cause these changes? Because there was no significant encephalopathy.
Okay.
Dr. Nihaal?
Yeah.
The contour of thalama, especially the medial part, they look little odd. Is there some atrophy, like segmental atrophy of thalama?
I would say so.
Dorsal and medial aspect.
Yeah, possibly.
In fact, the lower one, is there some system change?
No, this is just the CSF. You mean this part?
Right.
This is just the.
And even
this is just
GRE also. What is that dark areas in the medial aspect?
Yeah,
of
that I'm
thalami?
not able to ask. I'm very not sure, because the images, there's so much distortion now. If there are calcification or not.
Okay.
They probably are internal cerebral veins, looking at the symmetry of them.
Yeah, I guess so. Yeah. So the question is, yeah.
Contour of the cysts within the basal ganglia, they don't look like the acquired injuries, isn't it? Generally, tend to become much
they are
more
linear. Yeah, they are more linear and follow the direction of the putamen at least.
Does this point to a mitochondrial respiratory complex deficiency?
Possible.
Cavitatory lesions.
It is possible, I would say. So I would think I would go down the path of striatal necrosis, evaluate clinically if it's a progressive and non-progressive disorder, and evaluate accordingly. Interferonopathy, I don't think clinically it matches. I'm not sure. Maybe Romit or Dr. Amish can help me out with that. But ADAR1 mutation can also present with the bilateral striatal changes and possible calcifications within them. So I'm not sure if the GRE changes, if these are calcifications or not.
Nihaal, is the brain myelination abnormal on that T2 axial high cut? The first one on the top. I cannot see any white. Yeah. How old was this child when this
8 months. 8 months. 8 months.
8 months. It looks very flat. Image.
I think the quality of scan is slightly grainy appearance of the entire scan.
I cannot see any white matter there in that image.
Any other suggestions? So the question is, do we go to genetics or sequencing if affordable? Any other investigation?
Yeah, I think genetic testing should be done, because such mild or very non-specific symptoms in neonatal period, no encephalopathy, doesn't explain these changes.
Yeah.
I'm in favor of genetic testing.
Dr. Prasad has raised the possibility of pyruvate DNA.
In the best labs, the diagnostic yield in mitochondrial disorders is at the maximum 70%.
So we'll still try out for a whole exome, Romit?
Yes, sir.
Okay. This next case is Dr. Lokesh. I think Dr. Lokesh is in there. It's a 10-month-old child with acute encephalopathy and microcephaly. I think I'll just go on to the images. Rashad, you are there?
Yes, sir. So this child has a normal perinatal period, sir. Actually, antenatally, a child was diagnosed to have a periventricular cyst. So after delivery, on the day 6 of life, the child underwent MRI imaging. After that, child had normal development. Now at 8 to 9 months of age, 10 months of age, child presented with acute febrile illness. After 5 days, the sensorium started to deteriorate, and by the time the child presented to year, the child was having respiratory failure. So had to intubate and kept on in PICU. So after that, while in PICU, child was having sigh breaths. So we suspected lesion in the MRI, so lesion in the medulla. That's why we repeated second imaging.
Okay. Maybe you want to go ahead with the imaging also, the findings of the scan?
Yes, sir. So there is a diffuse white matter hyperintensity on T2, which is getting suppressed on the flare images, and white matter involving even anterior limb of internal capsule post, and midbrain is getting involved, sparing the red nuclei, and bilateral cerebellar middle cerebellar peduncles and pons are also involved, and corpus callosum, both the genus, body, and splenium were involved. Restriction, subcortical white matter and periventricular white matter are involved more posteriorly than anteriorly. The external capsule and internal capsule, and more perito-occipital white matter is getting different restriction more when compared to the frontal white matter. And there is a rarefaction on flare, cystic changes, and periventricular cysts were there. And in MRS, we can see inverted lactate peak at 1.3 ppm.
Okay. Yeah. So that's nicely summarized. Just to add to the corpus callosum, there is outer sparing of the outer blade of the corpus callosum is spared. Subarachnoid cysts, refractory changes of the cerebral white matter. The diffusion changes, if you appreciate, is more in the areas where there's no rarefaction, whereas the superficial white matter demonstrates the restricted diffusion is more in the central white matter and also in the cerebellum. So going by this, Dashath, do you want to come to a diagnosis? Possible diagnosis?
Yes, sir. So with this, we thought of vanishing white matter disease, and when we went into review of literature, we found a disease entity called a Cre-leukodystrophy, where the classic MRI findings of our child were found, like sparing of red nuclei and diffusion restriction predominantly in the perito-occipital region and sparing of frontal white matter, and having lactate peak in the MRS. So all these features were described in a specific entity of vanishing white matter disease called Cre-leukodystrophy.
Anything else to add? Dr. Darnath, Aidan, Dr. Udani?
Nothing to add. Like you nicely mentioned, the inner blade of the corpus callosum involvement gives it away in association with the other findings.
Yeah, this is actually from Australia.
No, I think I was just thinking, is there any possibility of a mitochondrial leukoencephalopathy like complex 1 or something?
Yeah, so the corpus callosum is a helpful clue. The image on the left is the vanishing white matter, where the inner blade is more commonly involved. Whereas if you see, this is a mitochondrial leukoencephalopathy, whereas the middle blade is more commonly involved and more significantly involved in the mitochondrial disorder. Also, the refractory changes, the diffuse refractory change is slightly abnormal for a mitochondrial disorder with these areas of myelin sparing regions. So I would think the first possibility would be vanishing white matter rather than a mitochondrial disorder.
Sure.
Just one question, Dr. Nihaal. How common is elevated lactate vanishing white matter? Is it very common?
If there is metabolic decompensation and lactic acidosis, I think you can find the elevated lactate.
Okay.
Because if you see there is acute decompensation in the form of restricted diffusion, so there is some degree of anaerobic metabolism going on there. So I think that should not be a differentiating factor.
Was there any trauma or fever?
Dashat?
Sir, hello?
Any trauma prior to the fever?
A fever?
Yes, sir. Sir. Actually, this admission, child has acute febrile illness, sir. After
those are two things vanishing white matter disease at this age.
There is no history of trauma, sir.
No, but one of these two. So febrile illness is enough.
Will we get feedback of the genetic testing so that we can learn?
Yes, sir. We sent, sir, clinical exam and mitochondrial genome analysis. We'll get back to you once the report comes.
Okay, right. Thank you.
Thank
you. Moving on to our second last case. It's from Dr. Ramesh. Dr. Ramesh, do you want to quickly give us the clinical inputs for this case?
This child was, I think, normal till 2.5 years of age, then progressive neurological complaints with motor regression followed by cognitive milestones were lost, and there is progressive vision impairment also, some optic atrophy as well as cerebral component both, and generalized spasticity, no epilepsy, no myoclonias. Yeah, so clinical possibilities were of a degenerative disorder, but was not able to fit into either a classical leukodystrophy or gray matter disorder.
Moving on to the images, and we have the T2 axial images on top. You can appreciate this significant extensive confluent abnormalities with the posterior to anterior gradient involving the parieto-occipital regions, the periventricular white matter, and also the areas of the occipital region and temporal lobes. There's also involvement of the dorsal midbrain and also the corticospinal tracts. On the sagittal images, you can appreciate there is involvement of the mid and posterior segments of the corpus callosum. Generalized reduction in the cerebral and cerebellar volume was noted. On FLAIR, there is some rarefaction of the involved white matter with some peripheral hyperintensities. Diffusion, again, very faint areas of restricted diffusion along the peripheral components of the confluent white matter abnormalities. We had a post-contrast study suspecting a paroxysomal disorder such as X-linked adrenoleukodystrophy, and you can appreciate this peripheral components, predominant peripheral areas of contrast enhancement, and also in the brainstem. Then on the SW images, you can appreciate that there's this florid areas of confluent areas of calcification, and we got a CT scan done, and you can see that there is extensive florid calcification involving the parieto-occipital white matter. Spectroscopy was done in the white matter. You can appreciate there is a lactate peak, and there's also an elevated lipid peak. The spinal cord also demonstrates this long segment involvement, especially in the cervical cord. So based on these findings, these are the possibilities which we thought of. Primarily paroxysomal disorders, X-linked adrenoleukodystrophy on the top list. We also had a case last year. I think Dr. Ramesh and Dr. Prerna have seen this child of a PEX5 mutation, again presenting with this confluent white matter abnormalities in the posterior cerebral hemisphere, and also demonstrated these areas of calcification with them. PEX6 was another possibility, with maybe less likely based on the other imaging findings, but this is also a possibility of a paroxysomal disorder with a posterior to anterior gradient involvement. So these are the at least imaging possibilities which we considered. And Dr. Ramesh, if you have any follow-up or any.
Yeah, so this is a girl child, just to add to the clinical information. That's why ALD was not an initial consideration. And I think this is the second scan, isn't it? It has shown progression from scan 1 year back, if I remember right. These calcifications were there earlier also, but they have progressed significantly over 1 year period. The genetic testing did not reveal any abnormality, but we have not specifically asked for peroxisomal group of disorders. So I have asked for a reanalysis of this one, just to ask, are calcifications so dense described with peroxisomal disorders?
Yeah, this is not as dense as what we have seen. At least the PEX5 case had more significant calcification. This is from literature. They are known to have spotty areas of calcification, but not such a florid appearance. At least I have not seen anything in literature with such significant calcification. If anyone else wants to comment on the finding.
There is one case in literature, Nihaal.
Okay. I think
this is in Annals of Indian Academy of Neurology.
Yep.
They have titled it "Florid Brain Calcification in a Child with ALD, X-linked ALD."
But it's if you see the image, it looks more like spotty. It's not confluent.
No, it's not as bad as
what you're seeing here. Yeah.
Would you consider possibility of LBSL? Because sometimes even mitochondrial disorders may have calcifications.
Calcification. But the contrast enhancement, it's more confluent, no? The enhancement, it's more going along the peripheral aspects.
Okay. Because sometimes even in mitochondrial disorders, we do get some patchy enhancement, but yes, it is a lot of peripheral enhancement.
Yeah.
Usually we don't see.
So there is involvement of posterior thalami as well as posterior putamen, isn't it, in this scan, which was not there in the earlier scans. Is that right?
And that I'm not able to clearly say because it's just the white matter which is coming.
The previous page, the first page of scans, or the next page maybe. Yeah, this one in the top row, second image.
Yeah. So is this just the white matter which is going beyond spondylosis involvement, or is it primarily involving the putamen? At least, yeah, you can see over here. Yeah, but that should probably be expected.
If you see the epicenter of the lesion, it is all posterior. If it was putaminal, the epicenter of the lesion would have been putaminal.
Yeah.
How old is the patient?
Pardon, sir?
How old is the patient?
This child is currently around 4 year plus, but started symptomatic at 2 years of age. Normal development till 2 years. Just continues to regress. Almost all milestones are lost over 1.5 period.
It looks like an encephaloclastic condition, with evidence of volume loss, dystrophic calcification over there. I don't know. Maybe progressive encephaloclastics, maybe something like a vasculitis. I don't know. Vascular involvement.
So this thalamic and basal ganglia involvement can also be seen with PEX5 or PEX6.
Yeah, so this is our case, Dr. Amish. If you see over here, the thalamus.
Right.
I think you must focus on the gradient of involvement, as Dr. Taranath said. There's predominant white matter going up to the, so there can be some areas of involvement over here, but it's primarily a white matter disorder.
What age do you normally present? I mean, PEX5 is a biogenesis disorder, so it should usually present much earlier. And normal development till the age of 2 is very strange. Unless it's a, like ALD, it's a specific enzyme is one thing, but biogenesis is all the Zellweger spectrum group of disorders.
So the PEX5 was a 4-year boy. Yeah.
When started symptoms?
The child had a regression of cognitive and developmental skills. since about 3 to 4 months prior to the scan. On examination, he had ataxia, cortical myoclonus, slurred speech, urinary incontinence, and there was no hyperpigmentation. So that was the clinical presentation, and there was normal long chain, very long chain fatty acids. TMS, cortisol, and lactate were also normal, but the clinical exome sequences picked out a PEX5 mutation that is Zellweger type 2A. So yeah, this is a child which we had, I think, last year. It's a 4-year child, and it's a boy.
Any positive eye signs for this child? Dr. Ritesh? Sir, any positive eye signs for this child? Even in PEX disorders, we expect some amount of eye abnormalities also. Maybe it can give a clue.
The index case has only mild disc pallor, which has appeared over time. Initially, it was not there.
Okay, so then it is also non-specific. Okay.
Okay, we'll probably get back once we have the diagnosis.
Yeah, sure.
This is just a follow-up case. I think Dr. Udani, Dr. Lokesh, and Dr. Madhavi have seen this child. The father is there in the attendance. Unfortunately, the child passed away last month. So this was a child who presented with a duration of illness starting in March 21 in the form of progressive cognitive and motor regression, which was associated with dystonia. So there was recurrent episodes of neurological abnormalities. Over the time period, there was gradual progression and the child deteriorated. Child was sent for whole exome sequencing and mitochondrial genome, suspecting a mitochondrial disorder, and there was no pathogenic variants. This case was discussed previously here and also at the GOSH grand rounds. Dr. Taranath, if you remember this case, I think we just discussed when you were there. But I'll just show the finding. Yeah, I'll just show the findings. Predominant involvement of the bilateral global pallidi in the form of some cavitated lesions, some asymmetrical involvement of the brainstem, but coming down, lower aspect is more symmetrical. The corticospinal pyramidal tracts are involved, and as you can see, there are central areas of necrosis and cavitation, and there's peripheral enhancement. No hemorrhage or calcification on SWI. Going to the next scan, you can appreciate that there is again areas of abnormality in the global pallidi. And another clue for mitochondrial disorder is the predominant involvement of the middle blade. At least that is what we thought of as a possibility. Again, the predominant involvement of the global pallidi. There's additional involvement of the splenium in the follow-up scan. Brainstem was again involved. In the October scan, there was a progression of the lesions. If you see on the deep brain nucleus involved the corpus callosum, frontal white matter, the posterior splenium aspect of the corpus callosum was involved. Differential areas of restricted diffusion more along the frontal and the corpus callosum. Progressive volume loss, but I think that can also be secondary or attributed to the treatment being given. But again, you can appreciate there is progression in the lesions of the deep brain nuclei in the form of now cavitatory lesions. Spectroscopy demonstrated the lactate peak, and again involvement of the middle braid of the corpus callosum. At that point, we discussed this with the GOSH group and also CHOP, and we thought of a strong possibility of a mitochondrial disorder. The other less likely differentials included were frontal ALD and ANE due to RANBP2 mutation. RANBP2 was reassessed and it came out to be non-significant. Mitochondrial genomic sequencing was did not identify any gene. So the father had contacted me and he wanted, because this child has an unidentical twin boy, he wanted to know what can be done to prevent or diagnose this condition, or is it possible to be there in that child also, though we don't have a primary diagnosis of the index child.
Them to breathe.
This girl had COVID antibodies positive.
Yes, Dr. Mani.
Which whether this was just progressive viral disease.
But it is slightly, symmetry is slightly unusual, and also I mean, it can be there, but when you got a lactate and the corpus callosum also, so we found it slightly.
Lactate high in the surrounding regions or only in the areas of involvement, because that is non-specific. No?
Yeah, I would agree. The lactate is non-specific. What we thought was the.
She had high CSF neopterin levels and IgG is significantly raised to when the destruction was high.
We thought it was an inflammatory disorder, frankly, and
okay. Neopterin pointing to possible ICARD, Dr. Rudani?
No, inflammation, any sort of inflammation. Of course, the inflammation could be seen in genetic disorder as well. I don't know what does it. What is the lactate, CSF lactate, Madhavi?
So CSF lactate always have been on the normal range, 1.5 to. It was done twice.
I was not very convinced about the mitochondria, but it's possible. The first thing we thought of was actually atypical A&E following COVID. But the way, he had this hemorrhagic kind of lesions, cystic, kind of lesions in the wrong place, in the globus, but,
Yeah.
And then the way it progressed, it looked like, the whole corpus callosum had thickened almost. I don't know what it was.
Yeah. Yeah.
Actually, they were actually looking for a biopsy, but they refused.
So if you take it as even if it's a genetic disorder, what are the chances for the twin to get them? Because it's a non-identical twin. Yes, he is asymptomatic as of now. That was the father's concern.
I think there's some talk. Somebody's talking. I don't know.
Probably try that. Do you have anything to say, or maybe I go on to the next round?
I think that was. I think that is Dr. Lokesh's phone. Vishnu, if you can mute Dr. Lokesh.
So let's go on to the other drug which has been.
Okay. So do we need to test the child, Dr. Udani, the twin, for anything specific?
Frankly, I don't know. I don't think so.
Okay.
Do you have time for my case? Or you want to show it some other time?
I can show you a case.
Yeah.
Okay. This is the last case. So it's a 7-year-old boy born to non-consanguineous marriage, normal birth with developmental normal development. Came with complaints of fever for 6 to 7 days. This was followed by acute cerebral ataxia and brisk deep tendon reflexes, and also had abnormal behavior and had irrelevant laugh. Child was excessively sleepy during the first 3 days of stay. Any idea when the MRI was done, Dr. Udani? From the
it was
symptom
done outside. Unfortunately, we don't have those films, but it was essential. We did see it. They looked like a suspicious hyperintensity in the cerebellar peduncle middle cerebellar peduncle on the right.
Okay.
It was not definite. Like later on we sort of saw it.
So maybe if you can quickly run through the clinical presentation before I show.
Basically, he responded partially to the methadone, but he again reversed it after that, and then he's had let's go on fast. No?
Yeah.
Go to the next slide. This is my resident has done this, and then he sort of had a progressive encephalopathy with worsening sensorium, and right now he's on the ventilator almost 5 months later. With so the first brain MRI was normal, second brain MRI also was normal, and Then he came over here. He had only interesting thing, he had herpes zoster after 2 days of pulse MPS, and he also had COVID antibodies positive and the RT-PCR negative. And because of that herpes zoster, they thought maybe it's a viral kind of thing and maybe there's some immunity problems and all. But that's what they gave the IVIG and acyclovir, and nothing really happened. And then a repeat MRI was done when he had a acute crisis in the ward. And this was the MR.
Yeah, so this is the MR from December, and you can appreciate the cerebellar peduncle changes and also the abnormalities of the brainstem. There is a volume loss that of the brain in general that can be also secondary to steroids, but you can appreciate that there is confluent abnormalities predominantly in the posterior cerebral hemisphere, going up to the pulvinar thalamic nuclei and also involving the central posterior limboventral capsules. The mid and posterior anterior periventricular regions also demonstrate some signal changes. There is asymmetrical involvement. If you see, the left hemisphere is more predominantly involved in comparison to the right. And on the diffusion, there is restricted diffusion along the parieto-occipital white matter, the splenium of the corpus callosum, the peritrigonal regions, the posterior limboventral capsules, and also some areas of the periventricular regions in the frontal lobe. Spine scan was, yeah.
Go on.
Yeah. So spine was done. Yeah. I am not sure if this is a
central canal
abnormality or not. I don't find any signal change, but maybe there's some area over there. I'm not very convinced in the cervical cord. So at this point, Dr. Udani.
So he just kept worsening. Actually, he's in Vadia Hospital. I am actually go there once a week. So I've not seen him in the interim, but he kept worsening. And, they repeated an MRI because there was really nothing. And we had actually, the reason they repeated the MRI was they got a history of a bite from a rabbit and a scratch from a dog 1 year ago. And somebody thought of rabies, and I was very, because usually rabies involves the basal ganglia and the dorsal brainstem and stuff like that. So
yes.
Highly typical. But anyway, it was done. A repeat MRI was done.
But the bite was 1 year back, you said.
Bite was 1 year back. Yeah, not bite.
Okay.
It was a scratch of a dog.
Okay. Yeah.
And then they did a biopsy. Anyway, you see the MRI. I'll tell you what the is later.
The MR, you can see that the changes which were seen previously have now progressed, involving the frontal lobe is also significantly involved. Also, the central white matter also is completely involved. There is involvement of the basal ganglia. So overall, there is, and also the cerebellar changes and the brainstem changes remain.
Yeah.
Post contrast, I can appreciate some areas of peripheral enhancement, especially in the subcortical region, but not very significant. Diffusion, very mild areas of restricted diffusion, but that is expected for natural progression as compared to the first scan. So overall, a progressive disorder, predominantly involving the white matter, but also the deep gray nuclei and the posterior fossa.
What I mean, so summarizing, he had a subacute progressive encephalopathy with a little fluctuation, but not very much. And basically, he had an episode of herpes zoster. He had COVID, antibodies were positive, and probably he had COVID and he had the fever, which preceded this problem. And any thoughts?
That's a summary, and I thought possibly post-COVID demyelination, but they're not very specific.
No, he was given a lot of treatment for demyelination, but didn't really make any difference.
Okay.
Of course, that doesn't mean anything, but well, I tell you what, the only other thing, anybody any comment?
Anyone else want to comment on that?
I don't know, Nipah virus?
Sorry?
There is a Nipah virus was going on, no? Nipah. No?
I don't know. I always thought Nipah was an acute disorder because this was going on for 6 months, almost 3 months. It started in November, and now he's like almost in February. And the only thing was that he had a CSF IgG which was positive. So in the beginning, we just thought fleetingly of shall we get a measles antibody, and that came positive. So he had done in 2 places, and he's got a very high CSF measles antibody serum antibody ratio. So it looks like an SSP. And the reason why I presented this case was that there seems to be an increase in the number of atypical and many other cases of SSP which we are seeing post-COVID. And I don't know if Lokesh or Ramesh are there and other pediatric neurologists whether they have the same experience. So I think everybody's left. Is the problem. What do you think? The thing is that
EEG changes were there of SSP?
no, it was just slow. Never any changes. He never had myoclonic seizures. He never had seizures. He had a progressive encephalopathy. And the only reason I asked for it was, because you were, nothing was coming positive. So we decided to do this. And the CSF IgG and this, then of course you look at it, the posterior involvement is more the white matter involvement and the gray matter involvement, and it's like this is not the bright diffusion restricted white matter that usually happens with many, but SSP usually gives this dirty white matter and mainly posterior. Yeah. It can involve the basal ganglia as well.
Periventricular, yeah, but not very. The confluent areas are slightly atypical, I think.
But that
Dr. Prasad is asked. So there's a question. Dr. Prasad is asking: can it be possible of a herpes zoster immune-mediated change?
We thought of that as well. It could be a herpes zoster a disseminated herpes zoster kind of infection. I don't know, herpes zoster immune change, I'm not sure what that means, but he had COVID, and COVID is known to depress the immunity. We've seen SSP, there have been herpes zoster cases in adults. So there's a transient drop of immunity generally. At that time, you may develop some. I'm assuming that he was infected with the atypical measles virus, and that probably got precipitated by the drop in immunity. That's what I think. But it's just a very unusual imaging findings with so much of brainstem and cerebellar peduncle. So I thought I'd show it over here. And I was just thinking that is that particular case, the one who how many months was, something like, we did not do the CSF. Unfortunately, we did not do the CSF anti-measles. I don't know, it's a very unusual. That also was cystic and all that, so we did not do that. But similar kind of symptoms and progressive disorders.
Okay. I think that should be our last case. So let's end with that. And thank you once again, everyone, for your participation. Thank you, Dr. Dani, for coming by as a panelist on our session. Our next session will be on 11th February. Again, same time. You can send your cases to the email listed below. And the last date of case submission is 8th February. We'll try to keep it more short and concise next time. Probably stretch it to 90 minutes. I think we just